Our guest speaker today is Brandy Trepkowski, and she's from our Rural Health Clinic, along with Megan Burgess and Michael Lewis. They have a wonderful group practice over there, and if anybody is low income, they can also apply to be on a sliding scale with your program. And Brandy is just an ocean of information about immunizations and healthcare. So Brandy, they're yours.
Thank you. So today I'm going to talk to you guys mainly about adult immunizations. There is a little bit of overlap with immunizations for children and adolescents. So some of the times I'll reference something about children or adolescents in these slides. And then there's one vaccine in particular that I did include with the adult immunizations, but it really is geared to people up to the age of 45, and that's the last vaccine that I'll talk about. So we're going to talk about why we vaccinate. Immunizations have reduced and eliminated harmful and lethal diseases. They are safe. They go through years of testing before they reach the market. More adults than children will have illnesses that are vaccine preventable. About 25% of adults are vaccinated appropriately in the U.S. That's about 1 in 4, so I advise you to pick your friends wisely. An estimated 1.5 million people worldwide will die from vaccine preventable deaths. A good example of vaccine that has been very effective was the smallpox vaccine. So Mr. Jenner invented that vaccine in the late 1800s, and by 1972 we were no longer vaccinating because it had been eradicated. So right now the vaccine is on stockpile in the event that it's ever used in bioterrorism, but it is not routinely vaccinated. And we can only hope that all of our other vaccines will have the same fate. So how does all of this work? Essentially, the body is exposed to a virus or bacteria, and as it enters the body, they multiply and it causes the disease. Our body produces a series of white blood cells that will attack these germs. The first thing are macrophages. They attack the germ and leave behind an antigen. I think of them as like the dirty monster of the group. They show up all big and strong, they fight the germ, and they leave behind kind of this residue. That's the antigen. The B lymphocyte, which is another type of white blood cell that defends the body, it fights the antigen. It recognizes it as foreign and doesn't want it there. It then produces antibodies that protect the body in the future. The T lymphocytes are a white blood cell that attacks the cells that have already been affected. So eventually they kill all the cells that have already been infected by whatever virus or bacteria you've been exposed to. And they act as a memory if your body is attacked again so that you don't become infected. Now how vaccines work is we expose the person to the antigen. So instead of worrying about all the macrophages and going through that first stage, we introduce them and then the body starts to form the B lymphocytes and the T lymphocytes, which then create the memory. So that when we are exposed in the future, or if we're exposed in the future, we do not have to worry about the threat of disease. So there's different types of vaccines. Not all vaccines can be manufactured or made the same way, and that's because whatever you're trying to vaccinate someone against has to have the right environment for it to be effective. So not all vaccines can be given live. Not all of them can be given inactivated. So live vaccines contain live or weakened contain live or weakened viruses or bacteria. Inactivated vaccines contain viruses or bacteria that have been killed during the process of making the vaccine. Polio is a good example of that one. Toxoid vaccines are made from toxins of certain bacteria. A good example of this type of vaccine would be like tetanus. So we don't actually give someone an inactivated or a live form of tetanus. We give them a part of the toxin that comes from the tetanus bacteria. And then the body builds antibodies against the toxin, which then makes you immune against tetanus. So it's kind of like an inadvertent way of doing it. A subunit contains parts of a virus or bacteria, but it's not whole. It's not part of the whole virus or bacteria, therefore it can't cause disease. A good example of that would be like whooping cough. So you're getting like a piece of the whooping cough, but it's not actually full, so therefore you cannot actually get whooping cough from the vaccine. And a conjugate vaccine fight different type of bacteria that would have a polysaccharide coating, and polysaccharide just means many sugars. So it's like a thick, hard, like candy-covered, not really, candy-covered bacteria. So these vaccines specifically work to fight, to work bacteria that are somewhat more resistant and that people have a harder time building antibodies against. So they attack that polysaccharide, and then if you get them with multiple doses, you can build up antibodies more effectively. Some require multi-dosing or boosters. Most of your live virus vaccines require less vaccine because you're actually getting a weakened form or a weakened strain, and the body recognizes it as foreign right away and builds up antibodies very fast and efficiently. Whereas the inactivated or conjugate vaccines, oftentimes you need multiple doses or boosters because with time, they're just not as effective. So why do we vaccinate the elderly specifically? Why do we focus on this group over 65? It's because people over 65 have a decreased ability to adapt to environmental stress. They tend to be more susceptible to infections. They have more evidence of autoimmune and immune complex disorders. They have higher incidences of cancer, and they have diminished responses to vaccines. So it's not that something magical happens at 65. You don't turn 65 and then boom, your immune system's gone. But as you get over 65 and you keep approaching those elder years, these things happen more frequently. And that's my grandma. She's 95. So she's one of the reasons we vaccinate. These are the adult vaccines that I'm going to talk about specifically today. The pneumococcal vaccines, the shingles vaccine, Tdap, which is the tetanus and a whooping cough booster, Influenza Vaccine, Hepatitis A, Hepatitis B, and HPV. I am not going to talk about meningitis, even though we do vaccinate adults against meningitis, because it primarily is that 19 to early 20-year-old age group. And honestly, at these luncheons, I normally don't get many people in that age group, so I thought I'd save you all the, the boring details. So first we're going to talk about pneumonia. Most pneumonia that we see is caused by Streptococcus pneumoniae. Streptococcus pneumoniae is responsible for not just pneumonia or an infection of the lung, but meningitis, ear infections, and bacteremia, which would be like having sepsis or a blood infection. About 18,000 adults will die from pneumococcal disease each year. And to fully understand like pneumonia, if you're looking at it from a respiratory standpoint, I actually liked this slide. So the trachea, we take a deep breath in, the air goes down in through the trachea, goes into the bronchi, which you really can't see in this picture, but it stems off and to go to each of the lungs. And then they go into these smaller branches called bronchioles, and then have alveoli at the end of them, and those are the little air sacs, and that's where air exchange occurs, or gas exchange occurs. So they're like, think of them as little tiny balloons that open and close as you take deep breath and close, or deep breath and expire. Inspiration, expiration, sorry. Now when you have pneumonia, these air sacs will actually become filled with fluid or pus or infection, and hence why people have, they'll develop fever, they'll have a hard time breathing, sometimes they'll have pain in the chest. So that's the main purpose of this vaccine. There's two types of pneumonia vaccines that we use. There's a pneumococcal polysaccharide vaccine, which we refer to as PPSV-23, and then there's the pneumococcal conjugate vaccine, which is PCV-13. So the PPSV-23 is a vaccine that covers 23 different antigens of the strep pneumonia. It's recommended for people 65 and older, although we do give it to people younger than age 65, but not younger than 2. If you're younger than 2, the vaccine is just not effective. It's not harmful, it's just not effective. So they just don't develop an immune response. It doesn't do any good. People that between 2 and 65 that would get the vaccine would include people that have chronic conditions such as diabetes, maybe cardiac disease, definitely our respiratory patients. So any of my patients who have COPD or asthma, chronic bronchitis, and poor immune systems, they would be able to get this vaccine one time before age 65 and then still get it again after age 65. Most of the side effects when you get this vaccine are site reactions, so sore arm, muscle aches, low-grade fever, fatigue. Now the pneumococcal conjugate vaccine, or the pneumonia 13, we call it Prevnar, is another trade name, brand name, covers 13 different antigens. They can't go together because if we put them in and made it just a 36 vaccine, those 13 wouldn't be effective in the way that the 23 is manufactured, and the 23 wouldn't be effective in the way that the 13 is manufactured. So back to that, one of the first slides when I was talking about the different types of vaccines, that's why these pneumonia vaccines are separated. So if you get both of them, you actually end up getting 36 strains of coverage of the pneumococcal disease. So this one we actually use in kids. So I vaccinate kids in my office at 2 months, 4 months, 6 months, and then between 12 and 15 months with Prevnar. And then that same vaccine can be given again after age 65. Some people can get it sooner than 65, but the conditions for Prevnar are a little bit more stringent. So if you don't have a spleen, if you've had a cochlear implant, it's not like all the chronic conditions that are encompassed in the other vaccine. And side effects are very similar to the pneumonia 23, arm pain, maybe some swelling, redness, mild fever, fatigue. Both vaccines are about $100 to $200 per vaccine, but Medicare covers both of them. I've never had Medicare not cover these. And most private insurances, actually, I have very few issues, if any issues, with getting pneumonia vaccines covered. Ideal situation when someone comes in and they turn 65 and they're there for their wellness check, we give them the pneumococcal conjugate one, so the Prevnar 13 first, and then 1 year later we give them the 23. These vaccines take several weeks for you to develop immunity, so you don't want to give them at the same time. Your body's not effectively going to build enough antibodies, and like we talked about earlier, people greater than 65 have a weakened response to vaccines, so we want to give them a little bit more time to do that. So this isn't instant immunity by any means, but you only need one after 65. You can get them as soon as 8 weeks apart if there is a reason to do that, a really good compelling reason. Maybe you're going in for, actually I've had this happen recently, a patient was going in for a transplant. So they weren't quite ready for the second one, but we went ahead and pushed it along because they met that 8-week minimum criteria, and we wanted them vaccinated before the transplant because afterwards it was going to be a year before they could be. So special circumstances. Oh, and I think I said it's readily available, so most of us have it in our offices, pharmacies, health departments, easy to get. This is shingles. This is a picture of a man with shingles. It affects about 1 in 3 adults in the United States. You had to have had a previous history of chickenpox, which is also known as varicella. Now, some people will get shingles and say, well, I never had chickenpox as a kid. Just because you never had the rash doesn't mean that you weren't exposed and built up antibodies at the same time. So most people, the vaccine came out in like 1991, I believe, is when we started vaccinating. So people after that, kids after that were vaccinated, might not have to deal with this, but pretty much anybody beforehand likely had chickenpox, and your risk of shingles is high. It's not contagious unless you've never had the chickenpox, meaning if you have shingles, you're not going to give in to me unless I've never had chickenpox. So the real theoretical risk now is for infants less than age 1. We vaccinate kids for chickenpox at age 1. So prior to 1, they have no immunity against this. So that would be my one concern, is if you have a brand new baby in the house and you have an active case of shingles, you'd want to stay away from them. But the general public, it's normally not much of an issue. And it's contagious with direct contact. So that's the other thing. Depending on where you get it, your risk of transmission would be higher. There's greater than 1 million cases per year. 1 out of 5 people that get shingles will develop post-herpetic neuralgia or other complications based on the location of where it's at. Post-herpetic neuralgia is a chronic pain syndrome that will develop long after the shingles is gone. So like this man that has the rash across his thorax, that rash is gone, let's say, within a month, but he might still experience pain and tingling and burning and feel like that rash is still there. And that's it's actually very miserable. And then other complications based on location, specifically referring to eye issues and ear issues. I've had patients who have had chronic hearing loss or even damage to the eye or vision because of it affecting the optic nerve or the otic nerve. So if many of you probably have either received or heard of Zostavax, which was released, let me make a note of this, I think it was in, what's on the next slide, 2006. And despite that being released and people starting to get vaccinated against the shingles vaccine, we started to still see a rise in the number of shingles cases as people got older. So then we realized we're doing something wrong with this vaccine. I say we, I really didn't have anything to do with it, but the CDC did. So in 2017, we introduced Shingrix. And the biggest difference, Zostavax, introduced 11 years sooner, was recommended for adults after the age of 60. You got 1 dose. It was given subcutaneous, meaning it was given like in the fat, typically in the back of the arm. It was a live virus, so you had immunity pretty fast. It was only about 50% effective, so not super effective. And by the age of 80, it was less than 18% efficacious. So if you got this vaccine at age 60, in 20 years, you only had about 18% chance of that vaccine actually working. And it reduced the post-herpetic neuralgia, which is one of the complications we monitor in shingles, by about 66%. So it actually did pretty good at reducing the risk of complications. And only a little less than half the people that got it had some type of a site reaction. So it was really well tolerated. It worked pretty fast. It was just a peak, you know, it works now, and then over the next 20 years, it wasn't doing a lot for people. In 2017, when Shingrix came out, it's a little bit less convenient because you have to get 2 doses 2 to 6 months apart. It's given in the muscle, so it's given up here in the arm, not in the back of the arm. It's a recombinant subunit with an adjuvant, meaning they added to the vaccine to make it more effective. And you can get it as young as age 50. We saw a 97% overall efficacy, so much better efficacy. And at age 80, it was still 89% efficacious, and that was the big ticket there. And if you looked at, we look at the efficacy rate in 10-year increments. So you can compare the two, and, you know, from age 50 to 60, 60 to 70, 70 to 80, and it was a steady decline. However, in the Zostavax group, it was a really rapid decline. Whereas in the Shingrix group, you went from 97% efficacious to just less than 90% over a 30-year span. So it's much stronger. The one negative side is that over 80% of people have a site reaction to this. The site reaction is not harmful, but it's annoying. And I do get phone calls about it because they're scared. You know, they don't always have these with vaccines. So they'll have redness, some pain, like, man, that shot, they remember it. Like, that shingles shot hurt. And that is not an uncommon thing. It's not harmful. It's just, like I said, a site reaction. And I think that has something to do with the adjuvant. When they have additives in vaccine, a lot of times you get more of a site reaction and people are just irritated by it. Tetanus is like that.
And what's the onset of that pain, and how long does it typically last?
Normally within 24 hours of receiving the vaccine.
Okay.
And normally within a week, the symptoms are all gone.
Oh, so you may have a little bit of pain for a week.
Yeah, but it's gradual. So like it peaks and then kind of goes down. Like by day 4, it's like, oh, it's still there, but not so bad. Some people will still be like, it's right there. I can feel the sore spot, but the swelling is gone and the redness is gone. Yes. Yep. Yeah, and a reminder, like that also means it's working and doing what it's supposed to be. I mean, not that it's bad if you don't have a reaction, because some people just, you know, just don't. But your body reacting is an expected finding with this vaccine.
And the alternative of not getting it is far worse.
Far worse. Yeah, the downside, and I can't find any, this is just my opinion, make sure I state that on the record, there's not great coverage for Shingrix vaccine. There is in the private sector, so people younger than 65 who don't have Medicare, like some of the Blue Crosses, I think HAP might cover it, you can actually get the vaccine covered, but it's quite expensive. It's $150 to $200 vaccine for each dose, so it's quite pricey. Yeah.
I'll just share, my aunt had severe chronic shingles.
Mm-hmm.
And as soon as the shingle vaccine came out, I went and I paid the big bucks to get it because I wouldn't wish shingles on my worst enemy.
No, it's very miserable. And then the cost of, the vaccine's expensive, but the cost of dealing with some of the complications that you might have can be just as bad. I mean, I have people that go to chronic pain management because of it. Yeah. It's horrible and debilitating, but Medicare does not cover it. And I think, again, this is my opinion, I think that it's just because it's not a life-saving vaccine. Like everything else that we talk about with vaccines, I talk about lives lost. I have no information on people dying from shingles because it doesn't happen. Now, I'm not saying it can't, but that's not a normal complication. So I think in some degree it's viewed more as like a nuisance or inconvenience or, well, they can deal with this. You're not ending up in the ICU or the emergency room, or if you do, you're released from the emergency room really fast. But you're not going to have a complicated stay from this. It's not easily transmitted for the most part. So I think the coverage is low because the cost coverage is low because of that. Because Medicare is great about covering things that are going to kill you. But I think, this is my opinion, I think it's not it doesn't cost the US millions or billions of dollars a year like some of the other diseases. But in my opinion, is it a worthy investment? Of course. And I try to catch all my people now at age 50. Like, get that vaccine now while you have private insurance, because it used to be, like the pneumonia vaccine, for example, if you didn't, even if you met criteria, some of the private insurances didn't want to cover it. But if you waited till 65, Medicare was going to pick it up. So a lot of people would wait knowing that it was going to be, covered then. And I get it. I mean, money, dollar's a dollar, but in this case, it's kind of the exact opposite. Don't wait for Medicare to pick it up. And there are ways that you can get it covered. The health department has a waiver program for people who can't, or if their insurance doesn't cover it. So even if you're 70, you know, and you're like, I really want to go get this, and you can't afford it, go to the health department. They'll put you on the list. There's ways around it. So the next vaccine is tetanus, or the next disease set, tetanus, diphtheria, and pertussis. So tetanus is normally contracted through soil and can lead to lockjaw and tetany. I feel like everybody knows what tetanus is. Everybody thinks rust, but it's not really rust. It's that you think more of the dirty, rusty nail that was in the barn floor that you know, so it's covered in dirt, and then it's, you know, got this bacteria, this toxin attached to it. Diphtheria is pretty rare in the United States today, but what it does is it causes a really thick coating in the back of the throat and on the tonsils, and it can cause breathing problems, heart failure, and death. And then pertussis, also known as whooping cough, is a bacteria that can cause respiratory difficulty. It's particularly harmful in infants. It can be fatal in infants. About 50% of infants that get this less than the age of 1 year will be hospitalized, and out of these, 1 in 100 will die. And it is a legitimate risk. So if you have a granddaughter or a child or someone who's asking you, hey, is your, you know, whooping cough booster up to date because you're going to be babysitting? It's a legit concern. It's worth getting, and it's not expensive. Medicare is not necessarily great about picking it up, but the vaccine's worth it. It's recommended 1 dose in adults and adolescents 12 years of age and older. So if a child all up to date on their vaccines, they should have had a booster at age 12, or 11 or 12. And then going forward, they really only need a tetanus booster. You know, they shouldn't have to have any more. But what happens to a lot of people is, I ask them, when was your last Tdap? And they're like, I don't know. And adults aren't required by law to be entered in MICR, which is a registration for immunizations in the state of Michigan. Children are. So currently, these kids, we're tracking really well, but it's all of us in the room that are not in the system, that have not been tracked real well, that if we don't have record of it, it's assumed that you haven't had it. So.
May I also share on this
Yeah.
point? Our medical director, Dr. Hammett, is also medical director of each of the thumb area health departments. And last year, there was an outbreak of pertussis in Amish families. And the health department, public health nurses went out. They were very culturally sensitive, and the Amish did want to be immunized for the risk due to their children.
Yeah.
And they were.
Yeah.
How do you get it? Is it just a
It's
virus?
respiratory. It's whooping cough is a bacteria, but it's a respiratory infection. And I've seen it. I'm gonna guess 5 cases, and I've been here 10 years, and I've had about 5 people that have had it. And like if you got it, I'm not saying it wouldn't cause a complication, but normally we would put you on an antibiotic and it would take care of it. But in infancy, it causes severe respiratory distress. So really, I'm telling you to get vaccinated to protect the babies, even more so than I am telling you to protect yourself. Yeah.
Is this the one, my son and daughter-in-law, when she was pregnant and having a baby, she said, anybody that wants to
Yeah.
have my child.
Yeah.
So the whole family went out
Yeah.
and got their Tdap.
Yep.
But during each pregnancy, the mom has to get
Mom does, because there is some transmission of the antibodies to the infant. And we don't start infant vaccines for whooping cough until 2 months. They can't get it before then. We don't do really any vaccines besides hepatitis B before 2 months. So they get it at 2 months, 4 months, 6 months, and then they get a booster at 12 to 15 months as well. So it takes that long to develop full immunity. So even after one vaccine, they're like, 10 to 12% immune. They don't have that much immunity. So that's what the protection is, and that's why they give it to mom. So if they give it to mom, there's some, maternal transmission, yep. And so they're hoping to bridge that gap of 2 months because the vaccine's not safe in kids under 2 months. So, and then the moms that breastfeed then offer a little bit more immunity yet.
Right.
Nothing's a guarantee. You're just hoping that it's enough.
You're
Yeah.
just doing the best you
Yep.
can within that.
And I actually had a 2-year-old little girl who was not immunized who had it. She's the only kid I've had with it. Otherwise, it's all been adults. And it's a horrible sound. It was one of those things in nursing school. Someone's like, if you ever hear it, you'll know it. And I did. I was like, what is that cough? Just sounds, it's different. It doesn't sound like any other cough. And it gets the term whooping cough because they whoop afterwards. They make this like kind of sound after they cough. And it's just very scary. And people normally come in to get seen because it's different than your bronchitis cough or an asthma cough. So yeah, pregnant women with every pregnancy, and when in doubt, I would tell you to vaccinate. So if you're like, I don't really know if I had it or not, get it, and there's no harm in any vaccine, any one of these up here, there's no harm in getting it more than once. So if you're not sure and you get it and then you find out, oops, I had it, that's okay. Your body's not gonna, if anything, it'll build extra antibodies. It's not gonna attack itself or destroy the antibodies that you've already made. So, and it's fairly affordable. So in my Medicare patients, if Medicare, because Medicare is not really picking up this one a whole lot either, it's about $50. If you have a secondary insurance or a supplemental insurance, some of those are picking it up. So, now tetanus is still recommended every 10 years without that whooping cough booster in it. And tetanus always has the diphtheria in it. So influenza, this is a viral infection that affects upper and lower respiratory tracts. So unlike pneumonia, where we're talking mainly like lower respiratory tracts and in the lungs, influenza will affect upper respiratory and then even the bronchi. And until AIDS, it was the last uncontrolled pandemic killer of humans. More people died in 1918 and 1919 from the flu than people that were killed during World War I. 20,000 people die each year from influenza-related deaths. There's several strains, but type A is the most common and severe. It has a 1 to 4 day incubation period, meaning you are going to have the disease and be spreading it long before, well, 1 to 4 days before you even have symptoms. When you do have symptoms, it's typically an abrupt onset. So when I see these people, they haven't had symptoms for 2 weeks. They come in because it started last night, I feel like I got hit by a semi, I think I'm dying, I have fever, chills, body aches. People say things like, my hair hurts, my eyelashes hurt, like everything hurts. They can't even describe it because I feel my fingernails hurt, like things that they would never complain about hurt. And it happens now, very, very fast. Usually I have a high fever with it as well, muscle aches, my joints hurt, I'm so tired, I can't keep my eyes open. Sore throat, almost always have a sore throat. Sometimes runny, stuffy nose. Vomiting, very seldom. Vomiting and diarrhea are not the flu. Say it 100 times and it'll still repeat myself because people don't always understand that. But people say I have the flu or the stomach flu. There is no influenza involved. It is not flu. It's just what we've coined it over the years. But that's not what it is. And the flu vaccine does not protect against gastroenteritis, which is what people actually refer to as the stomach flu. So this is all respiratory. We vaccinate due to the risk of complications and the risk of transmission. So like in the hospital setting, we vaccinate all of our healthcare providers to the best of our ability because we're likely to be those people that transmit in that 1 to 4 day incubation period and not realize it. So even though I might not be necessarily at risk for complications from the flu, I vaccinate faithfully because most of my patients are at risk. 70 to 80% of flu deaths are those people age greater than 65. And I agree 100%. When I lose patients in the wintertime in my elderly population, a lot of times we see flu. And 54 to 70% of those hospitalized for the flu are greater than age 65. And up until last year, I could honestly say that I had never had a patient who had the flu, true influenza, and had a flu vaccine get admitted. So we were always able to manage their symptoms outpatient, and they did fairly well. They might miss a few days of work, and I'm not saying they weren't sick, but I never had to hospitalize one until last year. But this was a man who was 74, 75. He had COPD, CHF, diabetes. He had a lot of complications. He ended up in ICU for 2 days for complications from the flu. Now his wife also got the flu, and they both were vaccinated, and she got the flu, and we were able to manage her symptoms outpatient, and she never had to be hospitalized. But he's my one, my only one. So right now, the recommendations for the influenza vaccine is everyone greater than 6 months of age. So this also kind of goes into vaccinating us to protect those infants because infants younger than 6 months cannot be vaccinated. Pregnant women can be, so same idea, we vaccinate moms. Sometimes there's, some cross, antibodies, but it's normally not effective enough. In infants, not just infants, in children under the age of 8 who have never been vaccinated, their first year they have to get 2. As adults, or after the age of 8, you only need to get 1 a year. It may reduce the risk of spreading, acquiring, and the disease severity. I have seen numerous people who have had the flu shot and still had the flu, numerous times. I would be lying if I said it never happens. But I can honestly say that they are not the majority of the patients that I see in the office. The ones that I see with severe illness are the ones who were not vaccinated. It's an IM vaccine, as far as what we are offering here, there is a live virus vaccine that is offered again this year. It was pulled off the market for several years because it just wasn't effective. And it's a nasal spray. So it's a live attenuated virus that's given through the nose. I didn't give any information about it because it can only be given to people ages 2 through 49 who have no health complications. So it's a very minuscule amount of the population, and no respiratory. So even an 8-year-old kid who's healthy and has asthma, they can't get it. They have to have no health problems. So it's a very small part of the population that can get it. And really the only thing we're doing is avoiding the fear of needles. It's not any more efficacious than the shot. Side effects: sore arm, low-grade fever, aches, headache, fatigue. Now this is where the whole "I got the flu shot and I got the flu" comes from. No, you didn't. Your body was building antibodies, like that very first slide we talked about, and doing its appropriate response, and so you had a normal side effect of the vaccine. And that's also reassuring. Sometimes I tell patients, that's actually a good sign. Even if you feel you feel like crap for a few days, it's good. That means your body is doing what it needs to do, because then after that few days, you've built up some antibodies and you're gonna feel hopefully better and prevent yourself from getting sick or as severely ill in the future. There are flu vaccines for people aged greater than 65 who contain more antigen or more adjuvant, and those vaccines are senior vaccines, we call them, or they'll call it the high-dose flu strain. And if you have an opportunity to get those, the recommendation is that they're not necessarily, they're supposed to be better. However, we don't want you to delay getting vaccination waiting for one. So if you went to your provider and they don't have it available, and you're like, well, I want to get it today, get the vaccine today. Don't worry about getting that high-dose strain or the high-dose flu. But if you have the opportunity and it's offered to you, get it. Take advantage of it.
Question. I know
Sure.
each year has different effectiveness depending on
The strains, yep.
Yeah, and some people think, oh, it's only this much effective, so it's
Yep.
not really it's not worth it. But I think personally it is worth your
Yep,
time.
it
'Cause
is.
Any bit is better than no bit.
Yeah, and sometimes it's not even, it doesn't mean that you won't get it, but you not getting it is severe and spreading it to other people. Yeah, it is. It's taking care of other people. And like last year, the success rates were pretty low. I think it was like 40%, which really for some vaccines is actually quite high. I mean, if we look at shingles vaccine, people vaccinate and that was 50%, and people did Zostavax and didn't even question it because they didn't want it. But yeah, realistically, it's worth any benefit. And there's also some belief that, so why flu is hard and why it has to change is because the virus changes so much. So some of these other bacteria and virus that we talk about, they don't change. Like tetanus is tetanus. The bacteria hasn't done anything in hundreds of billions of years. But flu is not like that. It's constantly it constantly is adapting and shifting. So very smart scientists are constantly going, okay, well, this is what it's done over the last few years. We assume it's going to go this way, and they're adjusting the vaccine. And then there's several strains, so they're looking at what are the strains that we're seeing. So the quadrivalent flu vaccine protects against 4 strains, 2 strains of A, 2 strains of B. So it's best to get the quadrivalent if you can. And there are a few trivalent vaccines, meaning they cover 2A and 1B. A is normally more severe than the B strains. We typically see A earlier than we do the B. So like a lot of times March, April, I'll start seeing like another, influx of flu patients with B, but they're just not as severely ill. They typically aren't as sick. So, and there are medications that can help reduce the risk of transmission and help in the event that, to help reduce symptoms, but it doesn't treat it. It's a virus. It's not a bacteria. Antibiotics don't work, but Tamiflu would be like a trade name. You're treating the symptoms, yep. And what you're doing is you're making the body change so that it's not really hospitable for the virus to replicate. So if you're taking Tamiflu, the virus is like, oh, this isn't a place I want to be. So it just kind of shuts down production and stops reproducing. The problem is, you can imagine, if it's making the virus feel that way, what do you think it's making you feel like? Tamiflu, I know I've had a lot of people that are like, I just want the Tamiflu. I'm like, okay. I personally would rather not take it. There's a lot of GI side effects with it. You don't necessarily feel any better. You're just going to feel better quicker, than you would maybe without it. So 5 days of feeling bad instead of 10 to 14 days. Another thing, the vaccine's very, very cheap. I mean, you can get it for free most places, even if you don't have insurance coverage. Employers give it, health departments, pharmacies. It's really easy to get. If we just looked at influenza too and I'm not a business person, but if I were going to be a business person, I would pay for my employees to get this because the amount of money with lost wages related to the flu vaccine. I mean, if it goes through a factory, I mean, you're talking every 2 days, every 1 to 4 days, you have another person dropping from the flu, and they're not out for a day. These people are out for 5 to 10 days. They're very sick, and you don't want them back, you know, or like the medical care facility. I mean, if it goes through someplace like that, it'll not only be deadly, but now you have all the employees that have it. You have no one to take care of the people that need to be taken care of. Or same thing in a hospital setting. You know, a small accounting firm with 3 people, it may not be as detrimental, but anything where there's a lot of people, it can be really bad really fast. Hepatitis A is a virus. It has an abrupt onset of symptoms, usually including malaise, fever, nausea, abdominal pain. 90% of people that get it will have yellowing of the skin and dark urine. And this, I'm referring to adults. Children less than 6 often have no symptoms. We vaccinate children to protect adults. So children are vaccinated at the age of 1 and 18 months routinely for this, even though really they don't have many symptoms and typically fare okay. It's that they transmit it to adults and we get very sick from it. In fact, people greater than 50, if you're going to have liver failure or death, it's going to be in that group over age 50. It has an incubation period of 15 to 45 days. That is so long. So you can be exposed, and it's going to be 30 days maybe before you even have symptoms. And you're still spreading it all during that time. It's transmitted fecal-oral, so it's kind of gross to talk about, but you're mostly done eating. Poop gets in food or water supply somehow. So sometimes that's from cross-contamination from sewer. Sometimes it's from going to a restaurant, maybe where they washed the lettuce and the employee that was cleaning the lettuce didn't wash their hands after they used the bathroom, and they have hepatitis A because they're an IV drug user. I mean, the list goes on and on. So you can't see it, but it is there. So yeah, it is gross. Yeah. But food contamination is the most common. So the hepatitis A vaccine is 2 injections. It's given in the muscle, given 6 months apart. It can come in a combination with hepatitis B, which we'll talk about next, making it a 3-dose series because hepatitis B is 3 doses. And again, it's never harmful to get more than 1. And we do this with kids' vaccines. Sometimes kids will get an extra booster of a shot because it's in a combination with something else. It's not harmful to them. It's just saving them from getting 4 or 5 pokes that they don't necessarily need. So it's the same thing here. If somebody needs hepatitis A and hepatitis B, you could give them both together. They're going to get 3 shots then instead of doing them separate and getting a total of 5 shots. They may have site pain, redness, low-grade fever, and fatigue. I don't get many phone calls on this vaccine as far as causing problems. You're at risk, and you should get it if you travel, if you're a homosexual man, if you have any drug use history, if you have chronic liver disease, if you're around a lot of little kids, if you work in healthcare, if you're just like, ew, that's gross, I don't want that, you can go get the vaccine. Recently, it's become way easier to get. I mean, they even have hepatitis A vaccine clinics where you can go in and receive it. I know of pharmacies, like our local pharmacies, I have patients that are coming in and say, well, I was getting my flu. They asked if I wanted my hepatitis A. So everyone's doing a really good job of promoting it. And if you're greater than 40 and you're exposed, so you're babysitting grandbaby, you get a phone call that, oh yeah, by the way, they had hepatitis A. Now they're not worried because the kid's fine, but you get the phone call, you can get the vaccine at that time. Vaccines, most of these take several weeks before you're immune. So some people can get something called immune globulin, and it's honestly the same for most of the vaccines or most of the viruses or bacteria. If you're exposed right away, you can get that, but that immunity doesn't last very long time. It just provides you with some antibodies to get you through the initial risk, and then you still have to vaccinate. But in the case of hepatitis A, if you're exposed and you know that, you could get the vaccine and still be effective. And it's about $60 if you pay out of pocket or don't have insurance coverage for it, so it's fairly affordable. Hepatitis B, however, is a little bit more serious. 200 to 300,000 cases new each year. Greater than 1 million people in the U.S. are carriers. It's associated with cirrhosis, liver cancer, has a longer incubation period, so these people cannot have symptoms for years, and still keep passing it on. And it is transmitted via infected blood or sexual contact, most commonly transmitted against adolescents and adults. Now, we vaccinate infants at birth for hepatitis B. So we're, in theory, protecting them with a vaccine that covers something that's actually sexually transmitted, but there were high rates of neonatal transmission of hepatitis B from mother to baby. And so what we found is kind of like that hepatitis A and the immune globulin. Instead of giving these babies immune globulin, when you find out later that mom had it, we just give them at birth. We're protecting them. And they had great reduction rates in infants being born with hepatitis B, which is why infants are vaccinated, because obviously they don't fit into this high-risk pool. So infants get a shot at birth, 2 months, and then 6 months. And adults, whoops, go to the next slide. It's a 3 vaccine series. Adults, similar, they get the shot. They can get the second one, I think as soon as 2 months, and the last one has to be at least 6 months from the first vaccine. If you are a healthcare worker, if you are homosexual, IV drug use, getting dialysis, have HIV, you definitely are at risk and you need to be getting that vaccine. Site pain, redness, fever, malaise. I very seldom get a phone call on the hepatitis B vaccine. Actually, I can't recall ever anybody calling me and having a concern. And it's very affordable. It's the #1 cause of liver cancer, so untreated hepatitis B. So if there's anything going on abnormal with your liver, get the vaccine. Don't even take the chance. And again, it's affordable, and most insurances cover it. HPV, human papilloma virus. By age 50, 80% of women will have been infected by HPV at least one point in their lives. It's spread by intimate contact during sexual activity. It does not have to be intercourse to be transmitted, but it's close skin-to-skin contact. It is silent. Oftentimes you don't even know that the person has it, that they're even infected, or that they're spreading it to others. It is associated with cervical, vaginal, anal, penile, and oral cancers. And about the 41,000 new cases a year, about 30,000 of them will be attributed with strains that are covered in the vaccine. So I put that up there. Michigan, these are nationwide, how we're doing. So compared to everybody else. And we vaccinate boys and girls. Girls, we fall into about 50% of our kids are, 50 to 60% are unvaccinated, are vaccinated. And then for boys, we're only like 40 to 49%. So we're not doing great. Better, but not great. The vaccine has been very beneficial in seeing reductions in HPV. We've seen about a 60% reduction in women between the ages of 14 and 24 who have had the vaccine and actually contracting HPV. It's a 3-shot series if you get it after the age of 16, and you can get it up to the age of 45. So this was recommended up until age 21, and then it was 26, and now it's 45. So we've been seeing some, I don't know if it'll go any higher than that, but it is definitely making a difference. It covers 9 strains of HPV, and there's hundreds of strains, but 9 strains, 7 that are linked to cervical cancer. Those are all the strains listed on the bottom there. Strains 16 and 18 account for about 80% of cervical cancers, and then there's also 2 strains of genital warts in there as well. That 16 and 18 strains, I see that all the time on pap smears. I mean, honestly, if it's abnormal, that's pretty much what we're seeing. So, you know, I kind of laugh because it's somewhat of a controversial vaccine, but I don't know why. It's no different than if you look at hepatitis B. I feel like this. Really, most parents don't question giving their child hepatitis B at birth, and we're vaccinating against something that's sexually transmitted and might cause liver cancer if it's untreated, and it's no different here. We're vaccinating in adolescents against something that would be sexually transmitted that they wouldn't know about and could potentially cause cervical, anal, or genital cancers. So I don't know why it is. Yeah.
I have granddaughters in
Yeah.
this age category, and their mother thinks they're going to all go out and have sex if they get
Yeah.
HPV vaccine. But mother is claiming that she was told that this is not very effective as a vaccine. Do you have any information about how effective it is?
It is effective, and that's where the reduction in the amount of cancers and cervical cancers that we're seeing associated with HPV. I think part of the controversy with it is that there's hundreds of strains of HPV, and we're only covering against 9. But at the same time, they are the 9 that we are seeing the most, and it doesn't mean that more strains won't be added. And then there's also some theory of like cross coverage. So if you're, covering against these 9 strains, and your body is exposed to strain 32, for example, your body still may recognize it as like, well, this is kind of like 31 and kind of like 33, so we're going to attack it. So just because the vaccine strain's not covered doesn't mean it's not effective against other strains, or that your body being, recognizing it as another strain.
Personally, I think it's something that's going to lessen your chance of cancer. That's a good thing.
Right. But it's hard. It's a hard conversation to have. You can give it as young as age 9. So you're talking to a preteen, in the room with the parent and saying, well, someday when they're sexually active and they're just like not my child, you know, because, and the kids aren't even thinking about, most of them shouldn't, you know, they aren't and shouldn't be thinking about it. But that's where being a parent comes in. We have to make those decisions knowing that our children someday are going to be adults. That is the goal. And someday they probably are going to be having sex and probably starting their own families. So, and you have no control over what other people do. So like I have boys, I don't even have girls. And I think about that with mine. Like I really hope they make great decisions, but I have no idea who they're going to be with when it comes to their future partner and what exposures they're going to get, even if they're with nobody else besides the person they marry. That doesn't mean that the person they married hasn't been with anybody else. Yeah. And I have lots of stories about HPV and, you know, girls who weren't vaccinated.
Oh, sure.
Yeah, and cervical cancer at 21, 22, 23 years of age because they didn't want the vaccine, or parents didn't want the vaccine. Well, I would have got it if I'd known. Well, you know, your mom didn't want you to have it. Like go talk to her. Yeah, it's hard.
Looking at it as a parent for boys, how is this effective for him, other than helping him with future partners?
If he was a homosexual male, then his risk for anogenital and rectal cancers goes way down. But you're 100% right. Otherwise, in a heterosexual male, you're protecting his future partners. So him silently transmitting the disease and then potentially causing it in his future partner that would then have cervical cancer, maybe an incompetent cervix, have to have surgery, unable to carry kids. I mean, not just the cancer piece of it, there's other parts to that. So yeah, you're protecting your boys to protect their future partners. So no different than, I mean, protecting girls to protect boys that then would, you know, it's a crossover. Yeah. No, and it's hard, and that's why the vaccine rates are lower for boys than they are for the girls, because at least with girls, you know, parents can like, or women normally, or if the mom's in the room, can be like, oh yeah, well this makes sense, I want to do that. But with boys, they're like, no, I don't have to worry about it. No.
So.
No. Yeah, it's no more less beneficial or less harmful to boys or girls. It's equal across the board.
Now, I think when you were talking about it being very controversial, I think a lot of it is when it really first started, a lot of people were saying that this was killing people.
No.
This vaccine was causing kids to all of a sudden get sick and
No.
end up dying.
No, and it's no different than like the autism scare. There is no data, there are no studies. It's just that someone makes the connection, like, oh, my child got the vaccine on Friday and now we're in the ICU on Thursday. It's from the vaccine. No, it's no different than getting the flu shot and then 4 days later having the flu. You probably already had the flu before you got the shot and didn't realize it.
Right.
But if you've made that connection in your brain, it's really hard to unconnect that.
The big controversy.
Yeah, I don't disagree.
Like you said, one day they got the shot and the next day they're
Yep,
in
and
the hospital.
or like autism, you know, we see that like even though all that stuff has been refuted, and that's a whole nother topic, you know, the argument is still there. Like when you vaccinate an infant, if then something, you know, you find something along the way, well, the only thing that's changed is this. Well, yeah, but they're also developing and maturing, and their brains are changing, and so you're seeing other changes. That does not necessarily mean that they got the vaccine. What about all the kids who have autism who aren't vaccinated? Or, yeah. I mean, you can infer a lot, but that doesn't mean that it's true. So how do I know what I need? Oh, and for the sake of time, I'm not going to click on it and show you. But if you go to that website, so it's at the CDC, and there's an adult immunization schedule. It's very interesting. You can click on it, and it just asks you like probably 10 questions. Are you male or female? Female. How old are you? Put your age in there. Do you have, you know, are you a healthcare worker? And it asks you like some specific questions. And at the end, it spits out what vaccines you should talk to your healthcare provider about. So it actually goes through and does all the risk stratification for you. So if you're, you know, on the fence and like, do I need this or not? It'll kind of give you a good idea of what you should have. It's not telling you to get it. It's saying these are ones that you should be eligible for or should be considering. So I did it on myself just because I was curious, and it was like it came up with Tdap and flu, of course, was on there, and there was MMR. Maybe I should consider MMR, which I didn't talk about because primarily we vaccinate children, but so I thought it was interesting. Talk to your healthcare provider. If your healthcare provider doesn't want to talk about it, they're not knowledgeable about it, go to the health department, talk to a different healthcare provider. Those are the hours for the Sanilac County Health Department, and a number that you can set up an appointment if you want to go in and have your vaccines reviewed. Most of the pharmacies are pretty good. When in doubt, vaccinate. If you get somewhere and you're like, I don't know if I had that, and they're offering it to you, it's okay to get it. It's not going to be harmful for you to get it again. In any of the vaccines we talked about. Now, so the MICR is the Michigan Care Improvement Registry, and we enter all child vaccines in there. In my office, we enter them for all adults as well, and I believe our emergency room does, and I think most of our offices in our system. It's not a requirement to do that, but it makes it a lot easier for tracking. And the pharmacies are supposed to be doing that as well. So oftentimes we can get on there and pull up and see, oh, you did get that. I did? Yep, you got it at Rite Aid 3 years ago. I did? And we have that conversation a lot because people don't remember. How can you possibly remember that amongst other things?
Do you offer all of the vaccinations you've talked about in your office?
Not the shingles. None of our offices offer the shingles vaccine.
So
And
you have to go to the health department?
the health department or the pharmacies will do that. So Rite Aid, Walmart, eHearts. And
Department is really good. I mean, I
yeah.
had tetanus this year. I didn't even feel it and afterwards.
Ooh, they did a good job, yeah. Yeah, we just don't offer it because of cost and finding out whether, so it's like in an office setting, we see the patient and then you bill for the service. So then afterwards you might find out something's not covered or covered. Well, a $200 shingles vaccine, most people aren't real happy to find out afterwards, and then, well, I don't want to pay for that. I wouldn't have got it if I didn't know if it was covered, and you're kind of at a, in a rough spot there. So we don't, the rest of them, then we know pretty good coverage. We have good coverage rates, so we don't have many issues, and they're just more affordable. So that's the only one. Resources, and just if anybody had any questions.
No, you covered everything.
Well, good. All right.